Hi, I'm Dr. Sunanda Kane, Professor of Medicine at Mayo Clinic in Rochester, Minnesota. I'm a gastroenterologist and just returned from our annual meeting of the College of Gastroenterology held at the end of October. And just wanted to spend a few minutes giving you some highlights of some of the bigger studies in the science that was presented at our meeting. There were two interesting papers on pregnancy. One was on the use of vedolizumab, which is known as Entyvio, which is an IV medication used FDA approved to treat ulcerative colitis and Crohn's disease. And because it's relatively new on the market, we don't have a lot of data about its safety during pregnancy. So this was a good opportunity to hear the experience of women who had been exposed to Entyvio before or during pregnancy, as well as a few men who had been exposed to Entyvio before conceiving a child. And while the numbers are small, that it appears that there are no important safety signals that have come from the exposure. We do know that, like other antibodies or monoclonal antibodies that we use to treat inflammatory bowel disease, that vedolizumab, i.e. Entyvio, does cross the placenta. But in these 26 occasions that when it was used during pregnancy, there was no signal that there were any increased risks for premature birth, congenital birth defects, premature rupture of membranes, or any of the other bad outcomes that we see with pregnancy. So that while the data are early, they are certainly encouraging, and that as long as we understand that Entyvio is being used to control inflammation and will cross the placenta after week 20 of gestation, that we have these conversations with our patients. So I think that that was very important early good news that was reported. The second study that was involving inflammatory bowel disease and pregnancy specifically was another paper coming out of Johns Hopkins, where they were able to use a national registry database looking at exposure to immunomodulators and having a diagnosis of some sort of autoimmune disease. So this was not specific to inflammatory bowel disease, but also would include lupus, rheumatoid arthritis, and other conditions for which azathioprine, 6-mercaptopurine, Imuran, or pyranethol, which are all basically the same things, were used during pregnancy. There did not appear to be, again, any significant safety signals when there had been exposure to these therapies during pregnancy. However, again, that because there was no information about specific disease activity, nor the actual disease entity that was being used, nor the doses of these therapies, just a yes-no exposure during pregnancy, it's hard to know what to actually do with these data, and that it has not changed my practice at all, which is to consider case by case a mother who is on one of these medications and whether she needs it to control disease. And thus we really need to wait for more details from that study to know what to do with it. Certainly it has not changed my practice as of this point. Another interesting study that came from that meeting was data from a community gastroenterologist who was able to survey his colleagues around the northeast area of the U.S. and asked them whether they employ the recommendations made from a very important paper that came out a few years ago in New England Journal of Medicine, and that was to, in patients with Crohn's disease, start both Remicade and an immunomodulator like Imuran or 6-MP at the same time, knowing that the combination worked better than either agent alone. And this was a landmark paper. Again, it changed the way that we practice, but interestingly, not in the community, that there's still a lot of concern and confusion about what the consequences are of using combination therapy, and that as much as we in the academic world believe the data from that study and have changed our practice, that many in the community are not, and that it's of great interest to us in the academic world to understand the reasons why that these recommendations from a very well done study that has really shown that patients do get better without any increased risks, at least for the first year on combination therapy, why that has not been more taken up and implemented in the community. So that there seems to be a disconnect in between the care that is received by primary private practitioners versus those who treat patients in an academic or university setting. So we are very intrigued at looking at the reasons why there is such disparity in care. With a new agent that's actually a pill called izanamide, and izanamide is yet another mechanism of action to suppress the immune system in a different way than any of the other agents that are available right now. And this was a large placebo-controlled trial where the results showed that patients who had moderate to severe ulcerative colitis did very well compared with placebo with this oral agent. And so again, these are very encouraging results, that these are going to lead to more studies and more choices and options for patients with these diseases, and that the future looks very promising for those patients who have failed or have become intolerant to the agents that we now have available, that we have other things in the pipeline that look very promising and are not just reinventing the wheel. Another study that was presented were the data that come from the trial that has now been submitted to the FDA for approval for Crohn's disease with an agent called ustekinumab, which is already FDA approved under the name Stelara for psoriasis. So this is very exciting because this is another biologic agent that works differently than Remicade or Humira or Entyvio, is already FDA approved and has been used by some academic physicians for the use in Crohn's disease. And these are the data now for the FDA approval in a large study of Crohn's patients who have active disease and given this agent first IV and then as a shot to see if it would help their Crohn's disease. And indeed, it does help their disease to the point where there is clinical relevance to their response, and that the safety profile appears very favorable, and we anticipate that Stelara will get FDA approval for the treatment of Crohn's disease as well as its already approved indication of psoriasis. Another study that was presented was the maintenance phase of Entyvio for ulcerative colitis. And as we know, Entyvio is already FDA approved to treat ulcerative colitis. This was follow-up data for maintenance of those patients who achieved remission through the induction phases of vedolizumab, and indeed showed that those patients who do have a response to Entyvio for ulcerative colitis continue to have a response into the maintenance phases with no new safety signals for extended use. So again, some very positive news about the use of these agents that have already been FDA approved, as well as ones that are looking to get FDA approved, and in the case of ozanimod, will go on to be further studied and hopefully get FDA approval down the road, and basically that we have now several newer agents with different mechanisms of action that can potentially be used for our patients who are intolerant of or who have lost response to the already available agents to treat their disease.